Hello and welcome to the Nursing Home Strategies to Reduce Avoidable Hospitalizations Part 2 webinar. My name is Michelle and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session, and during the question and answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Ms. Kris Modl. Ma'am, you may begin.
Thank you very much. Hello, everyone. This is Kris Modl with Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you this afternoon to this educational session entitled Nursing Home Strategies to Reduce Avoidable Hospitalizations, Part 2. All lines will be muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen, or place your question in chat and we'll address it later. This is the 4th webinar in a series intended to support nursing homes participating in the National Nursing Home Quality Care Collaborative's efforts to improve resident outcomes and reduce hospital readmissions. The first webinar in this series, entitled Reducing Hospital Admissions to Improve Resident Outcomes, Quality, and Financial Incentives, was recorded, and hopefully you've all had the opportunity to view this 24-minute webinar, which provides the context for these learning sessions. On August 24th, we presented the second webinar in this series, entitled Using QAPI to Reduce Readmissions, and during that session, a change of the condition process evaluation tool was introduced. Nursing home teams are encouraged to complete this tool to identify process changes that your home may need to focus on to improve communication about a resident's change in condition, which in turn should help reduce hospitalizations. On August 30th, we presented the first webinar that shared strategies that nursing homes are using to reduce hospitalizations. All 3 of the previous webinars are recorded, and a link to the webinar recordings and handouts will be shared at the end of this presentation. In this webinar, we have the privilege of hearing from nursing homes who will be sharing strategies they have implemented to reduce hospital readmissions and improve care for residents. As a reminder, the National Nursing Home Quality Care Collaborative uses this change package as a reference to great ideas and practices from high-performing nursing homes across the nation that have created interventions and maintained positive outcomes for residents and staff. Included in the change packages are strategies that these high-performing nursing homes have used to prevent avoidable hospitalizations. You will note that in Strategy 6, Provide Exceptional Compassionate Clinical Care that Treats the Whole Person, there are action items specific to the transitions of care between shifts, departments, and all care settings. Please use this link to access the change package. The first nursing home we will be hearing from is Luther Haven. I will now turn it over to Diane Landmark and Cindy Stinson to share the work they are doing to prevent avoidable hospitalizations. Cindy?
Hi, this is Diane Landmark. I'm a registered nurse and a PIP coordinator, and I'll explain what PIP is to those that aren't familiar in a later slide. I'm semi-retired director of nurses. I work 2 days a week, Tuesdays and Thursdays, and my job specifically is just working as a PIP coordinator and education.
And I'm Cindy Stinson, the director of nursing at Luther Haven.
Next slide. Luther Haven is located in west central Minnesota. Our capacity is 90 beds. We've been averaging about 80 in the last year. We're a church-sponsored nonprofit facility. Our purpose is to serve the elderly and disabled and promote their physical, social, emotional, and spiritual needs in a Christian atmosphere. We have 24-hour staff. Included in this is RNs, LPNs, TMAs, CNAs, and activity staff 7 days a week and into the evening shifts. Next slide. We contract with a rehab company for speech therapy, physical therapy, and occupational therapy. We have a clinic nurse practitioner that rounds 2 times a week to assist with resident needs and non-emergency orders, which is wonderful. We so appreciate that. And Chippewa County Montevideo Hospital, or CCMH, lab comes to our facility 2 times a week for lab work, lab draws. CCMH physicians round on a monthly basis, minimum of a monthly basis, in our facility. And we are physically connected to CCMH Hospital, so we have no 911 or ambulance services needed for our residents to go to the ER, which can be a good thing or a not so good thing. Next slide. For those of you who are not familiar with PIP, or PIPP, Minnesota has a performance improvement payment project which supports provider-initiated projects aimed at improving the quality and efficiency of nursing home care. Provider-initiated projects that are tied to state nursing home performance measures are selected through a competitive process and funded for up to 5% of the weighted average operating payment rate. Next slide. We chose this PIP project, reducing rehospitalizations, as we were aware of our use of the emergency department, and we knew this was a measure that was going to be identified and used in all facilities. We did a root cause analysis and learned that our physical connection to our county hospital made our use of and request for use of the emergency department too easy. We identified that we had a significant number of emergency department visits which involved hospitalizations, especially after hours. This problem affected our resident care in the fact that residents left their home to be seen by a provider that wasn't familiar with them. We have not addressed this issue in the past. We used numerous data to help identify this problem, including Minnesota Quality Indicators and Achieve Matrix software admission, discharge, and hospital leave reports, review of each emergency department visit and hospitalization, including the resident's progress notes, to determine if there was a trend involving the individual staff members transferring to the emergency department or hospital, as well as the day of the week that the emergency department admission happened and the time of day that the transfer occurred. Lots of data collecting, lots of manual data collecting, and also through our computer system. Next slide. As a goal, or what we were trying to accomplish, we identified that we were utilizing the emergency department for non-emergency appointments per our staff request and per clinic provider direction. We would actually call the clinic to make an appointment, and we would hear from clinic staff that they could not see a resident at that time because there wasn't an opening, and so they directed us to send residents to the emergency department. Therefore, our goal was to decrease these numbers through education and communication of all parties. Our goal statement was to decrease our emergency department and rehospitalizations by 10% over 2 years. This includes all payers and residents discharged to the community. To improve quality of life and care by reducing rehospitalizations and develop effective discharge planning processes for residents who are discharged to the community. This is difficult at times as the CMS QIQM numbers are for Medicare residents only, at this time anyway, and our PIP includes all payers. Next slide. Our first measure was
the nursing facility was to achieve a 10% improvement over the baseline on the following Minnesota risk-adjusted quality indicators. The baseline score is the facility reference line taken from the period ending September 30th, 2015. Hospitalization, and it was September 30th, 12.4% was the percent as of that date. Hospitalization rates within 30 days after admission for all facility annual admissions as determined from the average of the following 4-quarter rolling averages for the period ending. Next slide. So the nursing facility was to reduce the readmission rate to an acute hospital for short stay patients, which is patients that are here 30 days or less in our nursing facility, discharged from the nursing facility to the community and readmitted to the hospital within 30 days of the discharge from the skilled nursing facility by 10% for the measurement period. The readmission rate will be calculated as the number of hospital admissions per total patients participating in the follow-up interviews. The nursing facility is responsible for collecting baseline data for the period January 1-17 through June 30th, 2017, and submit it to the state by July 31st, 2017.
So a lot of information that we have to track and we have to continue to send in to the state so that we show that we're meeting our goals or we are improving. Measures we used to know if we were making improvements were the Minnesota Quality Indicators, CMS CASPER reports, Achieve Matrix software, admission, discharge, and hospital leave reports, review of each emergency department visit and hospitalization, including the resident's progress notes, to determine if there was a trend involving staff member and or physician transferring to the emergency department or hospital, as well as the day of the week and the time of the day that transfers occurred. We tracked which RNs at our facility had the most or the least emergency department admissions. Of course, we understood the time of day would affect this, such as if the clinic was open, if it was a weekday or a weekend. We shared this data at our first meeting regarding emergency department admissions with the professional staff, the RNs and the LPNs. This was an eye-opener for this staff. We learned some staff were not even attempting to call for clinic appointments. They were just taking residents to the emergency department. However, at times, the clinic staff was also telling our staff to take residents to the emergency department as they had no appointments available. Then we had emergency department physicians frustrated because they were seeing residents for non-emergency issues. At the end of our first meeting, the RNs and LPNs wanted to know what their data was. How many emergency department visits had they initiated, what was the time of day, and what day of the week it was. I hadn't intended on giving them that information, but I had it all written down. We were just going to give them the totals, but each individual nurse wanted to know where she was at. So we let each of them know individually what their numbers were. This wasn't shared with the group. Only the totals were shared. In 2017, the day of the week that was most used for emergency department transfers was Saturday and Sunday. Not a big surprise. This was in 2017 now. The time of day most used was 1 p.m. and 11 p.m. And that was kind of the 1 p.m. was a little, we didn't know for sure why that was happening. 11 p.m., of course, was midnight and close to, or was close to midnight. RNs and LPNs most used, the number one of the nurses used the ED department the most was 11, followed by 7. And the diagnosis that was most used was COPD. In 2018, from January to June 30th, just for the first 6 months of this year, the day of the week most used was Sunday and Thursday. Not real sure why that Thursday has happened, but no longer was it Sunday and Saturday as it was in 2017. And the time of the day most used for 2018 was 8 a.m., which was a whole new time for us. And we thought maybe that might be happening because the clinic doesn't open until 9. Not sure. And we had 2 RNs that had sent residents to the emergency department 5 times in these first 6 months, and 1 RN that had sent a resident to the emergency department 4 times. So those are things that we're looking at. That's data that we are collecting and that we're working on. We determined that our emergency department visits and hospital readmissions were reducing until we received our SNF VBP, which is value-based payment report, the end of August, and we learned that our numbers were minimally higher than 2015, which was the comparison for value-based payment. Final numbers for PIP payment are not in yet, as the PIP uses all payer sources to determine if we meet our goals, which means we use Medicare, Medicaid,
Medicare Advantage,
private, and right now CMS just uses Medicare. Currently, with this data, we are meeting our 10% reduction in rehospitalization goal for our PIP. Yay. Next slide. We decided education and communication was the primary focus and involved the medical director from the clinic and the hospital. We involved clinic staff, emergency department staff, hospital staff, and our staff, as well as residents and their family members. We did a root cause analysis and learned that our physical connection to our city, county-owned hospital made our use of and request for emergency department way too easy. If you're a standalone facility, you have to call an ambulance if you're going to take someone to the emergency department. We have the luxury of just putting that resident on a gurney or in a wheelchair and pushing them over to the emergency department because we are physically connected. We have different ownership, but physically we're connected by a hall, which is an advantage but also a disadvantage if you're looking at emergency room visits. In our Plan, Do, Study, Act cycle, the only barriers identified was the need for ongoing, constant communication and education of all staff, providers, clinic and hospital staff, residents, and family members. We met with staff from all areas, we identified problems, we developed a plan, and we have initiated it and are in the process of still initiating. We also continue to meet at least quarterly to review and revise this plan as needed. Next slide. Changes that resulted were improved communication with the hospital and clinic managers and staff. We'll continue to meet quarterly beyond the PIP project. We also feel we have improved communication and satisfaction with our staff, our residents, and their family members. Next slide. Interact tools were added to the admission packet given to residents and family members upon admission. Added discussion regarding residents' wishes, post and rehospitalization, and emergency department visits at care conferences. Any resident discharged to the community is called weekly for the first 4 weeks to determine if there are any problems that can be solved, to attempt to avoid a rehospitalization or an emergency department visit. Communication with home health personnel and or therapy who are making home visits is ongoing. Next slide. Meeting with clinic and hospital staff has been monumental. The clinic has now created a triage department. Our staff now calls the triage department for all clinic appointments, and they determine if that resident should be seen by a clinic physician or sent to the emergency department. The triage department also takes care of making room for a resident to be seen at the clinic. If it looks like all appointments are full, they figure out a way to get that resident into the clinic if it isn't an emergency. Hospital managers, including discharge planners, have been made aware of the need to avoid rehospitalization and are educating their staff of this need. The hospital is working on their discharge process to help make a successful discharge without rehospitalization. Continued audits of emergency department visits, which include what nurse was working, what day of the week, and time of day. Education to new nursing staff during general orientation is also completed. We also continue communication with home care agencies in the area as well as assisted living personnel and directors. Next slide. All of our staff were trained in the lean process to improve our discharge to the community and make that discharge successful. A discharge care conference is held prior to the discharge, which includes the therapy department, resident and or family, social services, nurse managers, and others from IDT if needed, to make sure equipment, medication, and follow-up appointments are in place upon discharge. Frequently, therapy does a home visit prior to the discharge of a resident also. Next, we started tracking discharges to the community in July of 2017. From 7/1/2017 to 12/31/2017, we had 19 discharges to the community with one hospital readmission within 30 days. We were unable to track any emergency department visits prior to that just because we didn't have the communication with the hospital that we now have. From January 1st of 2018 to July 31st of 2018, we have had 32 discharges to the community with one emergency department visit for COPD and 5 readmissions to the hospital within 30 days. One readmission was a fractured hip due to a fall at home, unavoidable. 2 exacerbation of COPD, may or may not have been avoidable. 1 acute CVA that was unavoidable, and 1 who was readmitted within 24 hours per request. This resident went home and requested to come back in within 24 hours. Decided that maybe home wasn't the best place to be. There was lots of discussion before that resident went home, and that resident they attempted to convince that resident to stay at least through the weekend, but there was just, that resident was going to go home no matter what we did, and of course came back in within 24 hours. Our goal remains ongoing at this time. We've had positive communication from our staff and residents and family regarding discharges and communication. We've learned that constant communication and ongoing education is necessary to be successful. And the next 3 slides give some indication of a portion of the tracking we are doing. So the next slide, this data is for the year 2017. It shows the number of admissions and the number of readmissions or emergency department visits within 30 days. These numbers do not include discharges to the community, but it is one of the tracking tools we use. Our average percent for this population in 2017 was 12.50%. The next 2 slides compare the first 6 months of 2017 and the first 6 months of 2018, sort of an apples-to-apples comparison. So the next slide, the months of 2017, January through August, our average percent was 12.68. We had 71 admissions during that time. The next slide, the months January through August of 2018, our average was 10.53%, and we had 95 admissions. An improvement. It should be noted that we really can't determine actual numbers until we are 30 days out beyond or past the last day of the last month. We determined our emergency department visits and hospital readmissions were reducing until we received our SNF value-based payment report at the end of August and learned that the numbers were minimally higher than 2015, which was the comparison for our value-based payment. Final numbers for PIP payment are not in yet, as the PIP uses all payer resources to determine if we meet our goals. Currently, with this data, we are meeting our 10% reduction in rehospitalization goals for our PIP. Next slide. Some of the resources we have used are included in this slide. We remain pleased and excited with this project. And I think that's all.
Thanks so much, Cindy and Diane, for sharing these great ideas. We really appreciate it. Some of you may have questions for Cindy and Diane, so if so, put them in chat now or enter the phone queue at the end of the session and we will address them. Our next speaker is Kris Modl from Dove Healthcare in Wisconsin. Kris?
Hi, good afternoon to everyone. My role is in today's presentation is twofold. I'm the Director of Social Services and Admissions for Dove Healthcare South Eau Claire and West Eau Claire. Next slide. Dove Healthcare includes 6 skilled nursing facilities and rehab facilities with 5 assisted living residences, all within a 60-mile radius of Eau Claire, Wisconsin. Our core services include rehabilitation, post-acute care, ventilator tracheotomy care, skilled nursing, long-term care, end-of-life care, assisted living, and memory care. We have a workforce of 1,000-plus employees, and we serve on average about 425 residents and patients per day. We also own and operate Transitions Rehabilitation, which employs over 90 physical, occupational, and speech therapists. Next slide. So when I mentioned what my role is twofold, I'm not only the Director of Social Services and Admissions and have been in this role at Dove Healthcare for the past 21 years, but 31 years total doing skilled nursing care. But I also serve as the co-chair for the Chippewa Valley Continuum of Care Coalition, the Transition Subcommittee. Our coalition was formed back in 2010 as a result of strategic planning. we knew we needed to improve transitions of care for the patients that we serve. Initially, our coalition was comprised of 2 hospitals, 5 skilled nursing facilities, and a family care organization. But as we grew, and today I'm very proud to say that we now include 4 hospitals, hospice agencies, home care agencies, CBRF, and multiple skilled nursing facilities. Our focus is to improve the continuum of care process as our patients or residents transition from the acute care setting to an S&F setting in a timely manner. We wanted to open up and have available to anyone who's interested in being a member of our coalition, so any organization or individual that has an interest in fostering the vision by actively engaging in the work and planning of our coalition. Next slide. So our purpose as a coalition has been to focus on improving care transitions. We wanted to make sure that we encourage person-centered and person-directed models of care, and with the overall purpose of reducing the number of rehospitalizations and also reducing the number of care transitions. Next slide. Our commitment. As members of our coalition, we join in a commitment to share best practices and the knowledge with each other. And this gets a little competitive at times because in all of our areas, there is a competitor, there's competition. And when we have other skilled nursing facilities and other hospitals, we needed to make sure that we were in a safe location, a safe place, that we could share information, kind of tear down some of those barriers so that we could forge ahead with improvements in our transitions for our patients and to make those transitions very safe and very efficient. So we're also looking at mentoring our partners and providers. For example, not all physicians or not all hospitals understand the regulations of a skilled nursing facility, and vice versa. As skilled nursing facility providers, we don't always understand why the hospital can do certain things and we can't, for example. We also wanted to make sure that we're able to share data and support the analysis related to the care transitions. Next slide. Our improvement goals help minimize transitions between entities and to ensure timely and consistent transitions with the ultimate goal to reduce rehospitalizations. We wanted to have a goal of improving the well-being of the community through collaborative processes that promoted optimal care and services, ensuring residents that their needs could be met, including behavioral needs, sharing data across providers, and improving transportation, which is kind of a hot topic in our area in Wisconsin right now, getting patients transported to and from different locations, because those folks right now that are on the medical assistance or Medicaid program don't have as many providers available to do the transportation. We're running into a lot of issues that way. We're also looking at improving goals in terms of developing tools and resources that members of the coalition can use to help with transitions, and also improve our goals in terms of education. Next slide. So during the course of all of the work that we've done since 2010, we have identified many gaps, and we knew that we needed to focus on those gaps in order for us to make some good changes. Some of our initial work identified gaps that have an impact in transitioning our patients. I just lost my slides. Including skilled nursing facilities with various capabilities. Not every skilled nursing facility is capable of managing certain type of residents. So, for example, wound management. Some facilities specialize in wound care where another facility may not. So we wanted to make sure that we identified in our gaps what facilities were able to meet some of those needs coming out of a hospital. We also looked at the gap in terms of the gap that we find with regulatory differences between acute care setting and skilled nursing setting. We also looked at and identified that there was placement challenges because of residents that may suffer from behavioral issues. Next slide. We also identified inconsistent and even incomplete information from the acute care setting. We weren't always getting accurate information or complete information to care for the patient. So, for example, at the time of admission, we were not always receiving a discharge summary that recapped the patient's course of stay in the hospital setting. Sometimes that was coming several days after admission, and so we were finding that we did not have all of the complete information at our fingertips at the time of admission. We also identified that there was a lack of education or lack of earlier education regarding advanced care planning. We were waiting too long to have those hard discussions about end-of-life care. Next slide. So we know that in terms of our improvements, that we needed to be working on some things, and one was the transitions. We'll know that if we have reduced transitions or rehospitalizations, if those are reduced, we know that we're making improvements. We also know that appropriate patient placement, that will be another identifier if we are making improvements. More timely discharges from the hospital, increased collaboration amongst providers, improved transportation, and improved overall collaboration and communication with each other. Next slide. Changes that resulted in our improvement, one of the things that we identified early on was that we needed to have better transfer communication in terms of when we're transferring people from one entity to another. How do we improve that transfer of information? So we developed a tool. It was initially developed, obviously on paper, and then for some of us that we were able to incorporate the paper format into our electronic medical record. It is based on the SBAR format, and so the skilled nursing facility completes a couple sections in terms of the situation and background as to why that person is being transferred out. And then once they're seen by the provider provides us evaluation results, a provisional diagnosis, and what the course of treatment is. We really felt this communication tool was needed because we weren't always getting back timely progress notes, maybe ER reports, etc. And so this tool has helped to improve the communication about how to take care of the patient if they leave the SNF. And then when they come back from the maybe the ED department or from a clinic appointment, we knew as a SNF provider what took place during the course of that appointment. We also looked at making changes with how our referral sources were sending us information. This is prior to electronic medical records that we now have remote access to. So I'm talking earlier on back in like 2010 that we identified that we needed to make sure that we had a standardized referral of information. So what I mean by that is that the hospitals locally were a little frustrated because it seemed that they were sending out various information to various skilled nursing facilities. One facility wanted A, B, and C. The next facility wanted X, Y, and Z. And so we decided to come together, hospitals and SNFs, to determine what exactly is it that we need for standardizing that referral of information. What do we need at the time of that referral being made that we can assess and have that be consistent and standardized? So we developed a standardized referral summary. That also led to having a standardization of what is needed at the time of discharge from the hospital. And so we came up with that as well. We also standardized our physician's plan of care, or the PPOC, such things as making sure that we have the statement on that PPOC saying that the patient is free of any communicable disease, etc. We also looked at some issues that happened with accompaniment to appointments. Residents that suffer from cognitive impairments being sent out for appointments and tests, and not really having anyone advocating for them when they leave the skilled nursing facility. So we've really shored up making sure that our patients are accompanied when they go out to appointments and tests, and coordinated those efforts not only with the clinics and hospitals, but also with the emergency contact, family members, guardians, etc. Next slide. We also needed to make sure that our discharge summaries were being received much more timely than what they were. When we initially started doing deeper dives into the time frame that it took from us to receive the discharge summary, we were averaging anywhere from 8 to 12 days status post-hospital discharge and not receiving that information until about 10, 12 days after. And so now, with our efforts, we have improved to less than 3 days. And now that we also have remote access to 2 of our main hospitals in our community, those discharge summaries much of the time are either accompanying the patient at the time of admission or we're getting them within the first day of admission. We also looked at improving facility capabilities, getting that message out to our providers so that the hospitals and the clinics knew exactly what type of capabilities each of the skilled nursing facilities were able to provide. Again, like I said earlier, wound care, for example. We also looked at improving the message that goes from the RN at the hospital to the RN at the skilled nursing facility. How does that handoff or that handover of care look? We developed a script, and so we wanted to make sure that there's consistency in terms of what exactly is it that we as skilled nursing facilities need in order to ensure continuity of care, and also so that the hospitals know exactly what is it that we're looking for. So we developed a script. And in a couple slides from now, I'll show you that script that we did develop. We also then formed 3 subcommittees, a subcommittee that focuses on education, one on transitions, and transportation. Next slide. So our subcommittee focus for provider and community education is to identify knowledge gaps regarding care transitions. We identify opportunities that improve our communication, our knowledge, and quality of care within those transitions. We also look at providing education to healthcare providers and community regarding healthcare resources and support along the continuum of our care. Next slide. The transition subcommittee focuses on monitoring transitions from both the acute setting and the SNF setting. We also are looking at improving the continuum of care process as patients transition. Next slide. And our transportation subcommittee centralizes their efforts in terms of compiling transportation resources to allow for multi-organizational access. We're also working on the collaboration with local and state levels to ensure services are available no matter the need or the payer source. Next slide. So some of our next steps that we're working on include the implementation of multi-directional flow of information. Come October 1st, the skilled nursing facilities in our community partnered with, again, in our coalition, identified the need that the flow of information needs to go backwards as well as forward. So we know that the information flows from the hospital to the skilled nursing facility, but then once the patient leaves the skilled nursing facility, seldom does it go back to the clinic or to the hospital. And so we're making the effort now come October 1st in putting that flow of information back to the clinic setting, to the primary MD. That primary MD will receive the current medication list, any recommendations from PT, OT, ST, as well as nursing, and the MD will also have the most current advanced directives, as well as any home care services that were set up for that particular resident. We're also working on educating receivers of that information, so we don't want them just to receive it and do nothing with it. We want them to do something with the information, primarily reconciling the medication so that no matter where that person is, that medication list remains current at all times. We're working on educating medical providers using healthcare resource utilization data. We're also sponsoring a community event in November to focus on advanced care planning and facilitation of setting goals. And we'll also continue with our ongoing collaboration with MediStar, where we're focusing on reducing all-cause admission and readmission rates. Next slide. So what you see now on this slide is the SBAR tool for the transfer of information. We took this information and actually we implemented it right into our electronic medical record. However, some facilities don't have the luxury of being able to do that, so then they use the paper copy. Next slide. And then what you see on the next several slides are the RN to RN handoff, where again it's based off the SBAR format. So the situation and background, the assessment. Next slide. Cardiac, pain, respiratory. Next slide. GI, GU, and then the next slide. So we're looking at skin, recommendations, etc. So in summary, the collaborative effort from our coalition members has been very instrumental in the progress that we have made in reducing hospital and improving care transitions. Thanks for your time.
And thank you, Kris. Great work. Again, if you have any questions for Kris, please put them in the chat. We'll address them after our next speaker. And our next speaker is Delander from Colonial Acres Healthcare Center at Covenant Village in Minnesota. Christine?
Hi, everyone. Thank you for having me today. So my name is Delander. I'm the Director of Nursing at Covenant Village of Golden Valley. Next slide. Covenant Village of Golden Valley, Colonial Acres, is located in Golden Valley, Minnesota. We're part of a continuing care retirement community with 14 communities across 8 states. So we are not-for-profit. We're faith-based community as part of the Evangelical Covenant Church. So Colonial Acres is a skilled nursing setting, and we have 88 bed capacity, 38 Medicare-certified beds, and the rest are private pay. Services provided include rehabilitation, so PCU, long-term care, and memory care services. Next. So part of our initiative here this year for reducing hospitalizations at Colonial Acres also revolves around the goal for overall campuses is to reduce readmissions by 10% by the end of this year. So according to the nursing home compare rate, we were 29.4%. And other reasons why this project is important to us is because we want to improve healthcare outcomes for our population, decrease avoidable financial penalties associated with readmissions within 30 days, be a responsible partner to our hospital systems, improve systems to help increase staff confidence, efficiency, morale, and effectiveness. Next. So how will Colonial Acres measure improvement? So a reduction in the hospital readmission QM, quality measure, to gain 20 or more points would be better for us. And then we're looking at better and longer transition of our residents in the community through our quality measure for discharges in short stay. And our goal is to achieve a 65% rate. As currently, we are 58.3%. And partly, we use our internal measure to reduce avoidable admissions through our Interact QI tool that is embedded in our EMR vision, and then also increase employee satisfaction regarding nursing home systems, and then increase employee recognition through Inspire to Serve, which is our employee recognition model. Next. So changes that will result in improvement in this. So earlier in May in 2018, we sat as a group and discovered that we did not have a system in place in the facility to guide staff on how to process changing conditions. So we partnered with Stratus Health and we introduced Interact into the facility and came up with a strategic plan that staff would follow on how to identify a change in condition and how to ensure that there's monitoring of the resident throughout the change in condition until they end up in the hospital, or if we decide to hold the resident in the facility and observe, then we had a process to follow. So we introduced Interact and utilized the interaction of Interact tools in our EMR. And then we worked with, like I said, Stratus Health and came up with a plan. We educated all staff in the facility on the new process or plan. And then we all complete our root cause analysis on anyone that goes to the hospital using the Interact QI tool. And we review all the admissions at the IDT meetings daily to ensure that we're looking at a root cause of what ended up, led to the resident to the hospital. And then we are ongoing doing education and re-education and bringing up the information in our QAPI committee. Next. So this is a change in condition process map that we implemented here at Colonial Acres using Strategic Health. So we use the Plan, Do, Study, Act process to come up with this from when a change of condition is recognized in the resident to when we decide to keep the resident in the facility and when an acute transfer is warranted. So this process involves all staff in the facility, not just the nursing staff, but also the nursing assistants and other non-licensed staff and family members as well. So this process helps us, from when a change of condition is identified from, nursing assistants or any other person that's not just nursing, discover this change of condition, we complete the stop and watch tool, and then that tool is handed to the primary nurse, and then the primary nurse does the assessment, and based on the assessment, they communicate with the families and the doctor, and also evaluate the pulse to see what the resident choice is. And then based on that, if the decision is made to hold the resident in the facility, then this process tool helps us identify what to do next and how to flag the chart to when the resident is sent to an acute health care setting, what happens thereafter. So we've embedded this in part of our EMR, and we've also embedded in our processes where all staff are following the same protocol, and also new hires are trained on it, so we have a continuum in what we do. Next. So progress to date at Colonial Acres. So from August 2018, which is when we reintroduced this system, is that we had 12 readmissions to the hospital after entry to the facility, from highest ranking being falls and then congestive heart failure. So we were able to identify this through using the QI Interact tool for identifying root cause analysis. And then our current rate, as I said before, was 29.4%. So our goal is to decrease this by 10%, and our internal measure right now shows that we're 17% from May 1st, 2018. And then areas of focus to reduce readmissions, which I mentioned before, is falls and PHF. So we have a performance improvement plan on those two areas, and we are working on building audit sets for congestive heart failure into our EMR, for all new admits with congestive heart failure, and also for our existing CHF patients. And then we've also implemented the fall team investigation to ensure that the root cause analysis matches a fall to prevent recurring falls, and all staff, residents, and family are being educated on our fall prevention plan on an ongoing basis. Next. So progress to date, further on, we are looking at partnerships with home care agencies with the readmission rate of 15% or below to increase our length of stay in the community. And then also we've been holding nursing meetings, and we introduced or we discussed Interact in those meetings, and also, did an informal survey, and staff reported feeling better about what they're doing. And then more formal surveys to occur in September this year to gauge feelings about the progress. And then nursing staff have been recognized by healthcare providers from Alina and North Memorial and our Methodist Hospital partners. And most of the comments that we get from implementing Interact in our day-to-day activities is that your nurses know what they're doing. Next. And these are the tools that we use. So we utilized all the Interact tools and embedded them in our Vision EMR. And so it's part of our day-to-day activities for what staff do. And we hope with time we'll see the numbers get better. Thank you.
Thank you, Christine. That's really great. And I do want to remind everyone that the process map that Christine shared that they worked on for change of condition is included as a handout for this webinar. So if you're interested in looking at that a little bit better, because it's hard to see on the slide, I would encourage you to have a look at that. It might guide you just on how your home can, this is just a great example of the QAPI process that you could do whenever you're trying to problem solve any kind of process in your nursing home. You can get a kind of idea of how Colonial Acres did that. They did a lot of work, I think months of work, so I think it looks like it's really paid off. So thank you very much. And thanks for all the speakers for sharing with us today. We really learned a lot. I know I did. So we now have time for questions or comments for the speakers. Operator, can you remind our participants how to get in the phone queue for questions or comments?
Yes, ma'am. If you have a question, please press star then 1 on your touchtone phone. If you wish to be removed from the queue, you may press the pound sign or the hash key. And if you're using your speakerphone, you may need to pick up on your handset first before pressing the numbers. Once again, please press star 1 to enter into the question queue.
Thanks. And if you'd rather ask a question in chat or comment, feel free to do that. As we're waiting for questions, why don't we go to the next slide? And on this slide, you'll see a link to the pre-recorded webinar that we recommended you all view, as well as the link to the Using QAPI to Reduce Readmissions webinar that was held on August 24th. And the link of the recording of the August 30th webinar, which was part 1 of the strategies to reduce avoidable hospitalizations. So in that webinar, there were 3 other nursing homes that shared some strategies. Please note we have added the link to that the webinar on August 30th to this slide, but if you run off the handouts at that time, the link wasn't available. So here it is now. If you have trouble finding any of these recordings, just let us know. We have a slide coming up on who you can contact in your state, and we'd be glad to share with you how to access those recorded webinars. Any questions in queue, operators?
Yes, I do have one question in the queue from Janelle Schurer. Your line is open, ma'am.
Hi, Janelle.
Hi, thank you, everybody, for this great presentation. I have a question for the first nursing home that spoke, the one that was from Minnesota. I can't remember your exact town. But what I was wondering is, what is your nursing home's relation to the hospital and clinic? I mean, is there any formal relationship? And then, so I'm assuming no, but maybe the answer is yes. But then I'm wondering, how did you work with them to help them want to change the process too? Because they were involved, especially I heard that the clinic was saying just take them to the ED.
Hi, this is Diane. You know, it wasn't a real easy process, but I think some of what helped a little bit was the fact that the hospital knew that at some point rehospitalizations are going to affect their payment also, and so they knew. Plus, they were getting. They were picking up on the frustrations of the providers and of the emergency department physicians. You know, why are you sending this resident over here with a cough when they should have been, it's not an emergency, should have been seen in the clinic. You know, and that has gone on for, oh my gosh, several years. They've had a big turnover in both the clinic and the hospital, and so I just started calling and emailing those new managers of both, and they were willing to sit down and have a first meeting. And once we had that first meeting, it was just so much better. Does that help?
Yeah, that does. And it's that face-to-face meeting people. Don't you think that really has an impact on making some change?
Definitely.
Yeah.
Definitely.
Yeah. Thank you so much.
Always, honey goes a lot farther than vinegar.
Yes, it does. Yeah, great.
And we actually, the first meeting, we offered a meal. It was a lunch and learn, and food always bring people in.
So, do you continue to meet regularly with them then?
We do. We don't have specific dates, but we're doing at least quarterly. I have a little flyer in my computer that says, you know, call again and set up a meeting, and they've been very willing to do that.
Oh, that's great. Thank you so much.
Yeah, it really has improved the relationship, yeah.
Thank you. Are there any other questions in queue?
No, ma'am. I have no other questions at this time.
Okay. So let's look at the next slide. So just a reminder, our last webinar in this series, Nursing Home Strategies to Reduce Avoidable Hospitalizations, Part 3, will be held on September 20th, so next week. You will need to register for this event if you haven't done so already, and you can find the registration information via the link on this slide. And thank you again to all of our speakers for sharing with us today. I think we all, this is great, valuable information. We appreciate all of your efforts to improve the quality of care and quality of life of those living and receiving services in your nursing homes. And if you have any questions about this webinar or about the National Nursing Home Quality Care Collaborative, please refer to this slide for the contact information for the lead from your state. As you exit from this webinar, a window will open to a short evaluation. And we're also including a link to the evaluation in the chat box, so it's there now. So please take a minute to provide feedback on today's session. Once you've completed that evaluation, you will receive a certificate of participation. This session was recorded and will be available on the Lake Superior Quinn YouTube channel in about a week or two. Thank you all for participating. Thanks our speakers, and everybody have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's teleconference. Thank you for participating.